energetic as usual. I've been under the weather for a few weeks, so hopefully I can get through this talk without coughing. But hopefully you can hear me since I have the mic. Okay, good. So one of the reasons I left USC after 10 years on faculty there and moved to City of Hope is because I really believe in immunotherapy as the way we're going to get lasting remissions for prostate cancer. And City of Hope is really at the epicenter of immunotherapy. They're creating new ways of activating the immune system. And so the big enticement was that I get to be part of these very innovative first-in-human, brand-new treatments for prostate cancer, and I'll talk a little bit about those. So this talk is going to mostly focus on immunotherapy. That's not to say we don't use hormone therapy and chemotherapy and radiation and all those others, but if you have questions on that, hopefully we'll have a little time at the end. So there are lots of different ways to stimulate the immune system, and a lot of times people will put up a slide and show you all the different parts of the immune system, but I opted against that. So I hope that the talk will be at your level, sophisticated enough, but also including some review of basics. If something just doesn't make sense, feel free to raise your hand and stop me. So we'll talk about vaccines, which haven't been so successful, but they are still in testing. There are some that are looking pretty good. And then Sibuleucel T, which maybe some of you have had. It's also known as Provenge. And then some of the newcomers to the scene, the immune checkpoint inhibitors. That includes drugs like Keytruda, Opdivo, Tecentriq that you might have heard of. And then finally, the new stuff that we're doing at City of Hope, the CAR-T and the BiTE antibodies. All right, so vaccine approaches have, generally speaking, been disappointing. We had these two big phase 3 trials of GVAX, one combined with Taxotere chemo and one head-to-head against Taxotere chemo. And in their phase 2 trials, they had seen some benefits, but the phase 3 trials were very, very negative. So what is GVAX? They took some prostate cancer cell lines that we use in our research in the lab, and they deactivated them and ground them up so that essentially all different kinds of proteins that might be in a prostate cancer cell would be represented in this vaccine. So unlike other vaccines that are often a single target and you're only activating the immune system against that target, GVAX seemed like a good idea because it could activate your immune system against a bunch of different proteins, and maybe your cancer has these 6 proteins but not these other 20, right? And yet it didn't seem to work out, and I don't think we really know why. Sometimes it's a matter of trial design, but I don't believe there's any further study of GVAX at this point. What's nice about a vaccine is it's super easy. You all get your flu shot and your pneumonia vaccines, so you know what that feels like. With some of these vaccines, they do get some welts and swelling at the injection sites, but aside from that, they're pretty well tolerated. So Prostate was the one we were waiting for. I might have even mentioned it in one of my talks years ago that there was this big phase 3 and we were waiting, and we were waiting, and we were waiting. And the longer you wait for a trial to report out, usually it means there's not going to be a big benefit. And sure enough, they finally reported out. So this was the Prostate trial. So that was against PSA, and it used a virus, but was not successful. However, there are some ongoing vaccine trials. Doug McNeil at University of Wisconsin, and then Oncology at the San Diego VA, so that's at least within striking distance. The Wisconsin group is studying an AR vaccine targeting androgen receptor using some co-stimulants, and then the Oncology one is a PSA vaccine. So that's vaccines. People often think about Provenge or Sibuleucel T as a vaccine, but it's not really. It's an activated autologous cellular immunotherapy. So we'll break that down. It means we take some of your immune cells, in this case dendritic cells, we activate them in the presence of a prostate cancer protein, we stimulate, and then we give them back to you, your own cells. So you're not getting anyone else's cells. That's what autologous means. They're from yourself. And so here again, the phase 2 looked good, and we wondered would that translate into phase 3, and in this case it did. So There was big controversy when it first got approved a dozen years ago because PSA didn't go right down and tumors didn't shrink right away and people's cancer still progressed, and yet they lived longer. And so there are some doctors to this day who say, well, it doesn't work. But when we're treating our prostate cancer patients, really our goal is for you to live longer and better. And I think Sibuleucel-T or Provenge really does do that for the right patient. So I usually show a slide of my patient who had a dramatic response, a complete response. It lasted for years. I was able to stop his Lupron. And eventually his cancer started growing again, and he's back on Lupron. But he had a really great response. So that is to say, for some men, this is a good treatment. Even if we don't see that PSA drop right away, they tracked down some of the early Provenge people 5 and 10 years later and drew their blood and could still see evidence that their immune system was more active against the cancer than it had been before the Provenge. So it kind of stays with you the rest of your life. It's 6 weeks, you're done. It's pretty non-toxic. It's just the hassle of having your cells collected. So do people know what a leukapheresis is? How they collect the cells for Provenge? So some of you do. So the blood needs to go into a machine and then back into you. So it means if you have good veins, you get 2 big IVs, and you have to sit there for 3 or 4 hours. And you do that 3 times for Provenge or CIP-T. So that's what people complain to me about the most. That's what they like least about it. But actual infusions, sometimes you get some fever or chills, but generally speaking, next day you're kind of yourself and you don't have ongoing side effects. So this one, if you stack it up against the other treatments like Taxotere chemo, Jevtana chemo, Zytiga, Xtandi, you can see that the kind of ratio of benefit is similar to all those other drugs for Provenge, Sibuleucel-T. So I view it very much like all my other tools for prostate cancer. It's not the only tool I'll need. We need Zytiga, we need Provenge, we need chemo. We use them all in sequence in different ways for different folks. And this slide or this study, the Schellheimer, is too old to include radium-223, but I suspect it would kind of stack right up in a similar magnitude of benefit. They broke it down by quartile, so this was from the original population. When this first got approved, people were flying in to get it. We were at USC, one of the first 50 centers to offer it in the country. And there was just this backlog of people who needed treatment for prostate cancer because there was nothing at that point. There was hormone therapy and there was Taxotere, and that was it. So people got treated a lot later, and they probably benefited less than they would today when we're using it in earlier stages. So the lowest PSA quartile, they broke it down in fourths, was 22. And those guys got, like on average, an extra year, where the average life extension for the whole population was like 4 months, which is pretty similar across the other treatments. And that's not the best way to look at the benefit of a treatment. It's just one way. If you're trying to understand whether one treatment's better than another and there's no head-to-head, you can kind of at least put it in context. So if you use it earlier, you get more benefit. Recent data shows that African Americans tend to get more benefit. They seem to have more activation of their immune system from Provenge. Why that is, I don't think we really know. Whether that applies to other immune therapies, I don't think we really know, but it was a pretty interesting finding. So the more recent quartile data where they took the PROCEED registry, which was after it had been approved and lots of men were getting it, they put some of them onto just an observational study so they could collect their data. And they found that men in the lowest quartile, in this case PSA less than 5, got the most benefit. So earlier is better. If your cancer's growing rapidly, if you're having pain from cancer, Provenge is not the treatment for you. It's more for someone who's had a nice response to hormone therapy or Zytiga or Xtandi, and now PSA is just starting to rise, but nothing's changing and you're feeling fine. That's the time to sneak it in and activate the immune system, in my opinion. So how could we make it work better? Because we would sure like for Provenge to induce more beautiful responses and drop those PSAs. So at City of Hope, before I joined, Dr. Twardowski had a study with SBRT. So SBRT is focal high-dose radiation. So like if you have a bone metastasis, instead of doing 10 treatments, 1 every day for 2 weeks, Monday to Friday, they can give 1 big dose or 2 big doses with very focused high intensity. So if you hear SBRT, that's what that means. So it's thought that radiation might kill cancer cells in a way that activates the immune system. So maybe if you zapped it with radiation and then gave the immune therapy, that we would see enhancement of response. But these survival curves suggest that there's not really much difference. So it didn't seem to do that. We just presented a study, I don't know if I have it in here, no? Oh, I do, okay. So we just presented this study of ProVench with Tecentriq, which is one of the immune checkpoint inhibitors, and I'll show you, but there was not really a positive result there. And then there was a study with prostate acid phosphatase, PAP, vaccine added to ProVench, but it didn't seem to augment activity. So we're still looking. We're still trying to figure out if there's a way to make it work better. This is the one combination study, I think, that actually is kind of positive, although it's a little hard to tell. So radium-223 is the radioactive particle. It's like radiation from the inside. You inject it into the bloodstream and it goes into the bone where the cancer is active, instead of radiation beams entering from outside. So radium-223, FDA approved, doesn't always lower PSA. Can be hard to tell if people are benefiting, but prolonged survival, just like ProVench, so they're kind of interesting bedfellows. But here's the waterfall plot. This is one way we like to show in a clinical trial who's benefiting. So everyone starts on this line in the middle, and if their PSA is going up, it means their PSA is going up. And if their bar is going down, it means PSA went down. So the red bars got the combination of ProVench and radium-223, and the green bars got ProVench by itself. So, definitely more bars going down with the combination, but whether you would have gotten that just with the radium-223, I guess, is the question. So not proof, but this was also kind of interesting. This is the way Dendreon, who makes ProVench, looks at whether your cells have been activated by their treatment. So every time you do that leukapheresis and they collect your cells, it goes to Dendreon, and they can take a little sample and run some tests to see how active your immune cells are. So the second time you get your dendritic cells collected, and the third time, you've already been exposed to their process, and so in a way they can see real time how your immune system is being boosted. And we look at it with these, I don't know what you call these, box plots or something. And so there's actually more immune activation with the ProVench. This is like what we saw in the original studies. And this activation that they measure in the product corresponds with survival benefit, by the way. And there's less of it with the radium-223. So, kind of interesting. I'm not sure if this will move forward, but this was brand new, just presented and caught my eye at GU ASCO up in San Francisco a couple weeks ago. So this was the poster I presented at GU ASCO in San Francisco a couple weeks ago. So we took atezolizumab, which is Tecentriq. So Tecentriq, Opdivo, Keytruda, Imfinzi, these are all immune checkpoint inhibitors. So your immune system all the time is looking for invaders and tries to attack the invaders, but sometimes they, by nature, are programmed to attack something of you, something normal. And so we need a system to turn those guys off, because we don't need our immune system to be attacking ourselves. When it does, we get diseases like lupus or thyroid or other autoimmune conditions, right? So we have these off switches. And cancer, because it starts out as us, can figure out to use the off switch. When the immune system comes up and wants to attack the cancer can push the off switch and say, nope, I'm part of you, don't attack me, go away. And so the Nobel Prize was actually awarded this year to Jim Allison and another gentleman who really discovered this whole system. There's more than one off switch, and there are lots of on switches also. And so now lots and lots of drugs are being developed to flip these on and off switches. They're being thrown together in random combinations, it seems, just trying to figure out, because these drugs were so successful, but there's still work to be done, and so now they're trying all the other switches to see if there's a better switch. But largely, the ones we have, like atezolizumab and just Tecentriq and Keytruda and all those work on PD-1, PD-L1, programmed death 1 and programmed death ligand 1. just one of many, many on and off switches. So these drugs are now approved in lots of different cancers, lung cancer, bladder cancer, kidney cancer, and they work pretty well, like 20 to 30% of people benefit. By itself, in prostate cancer, it's about 0 with this drug and about 9% with Keytruda, so pretty unexciting results. But we thought maybe what's happening with Provenge is the immune system learns that it should seek out and recognize prostate cancer and want to attack, but then maybe that off switch is being pushed. So it made a lot of sense to put together a blocker of the off switch together with the Provenge and see if we'd get more bang out of our Provenge. I can't take credit for designing this study. It's actually Charles Rosser, who was at University of Hawaii, now is at Cedars-Sinai, who designed this study, and he designed it to give 2 different sequences. Should we start with the Tecentriq for a couple doses and then give the Provenge, or should we start with the Provenge and then give the Tecentriq? And then we're going to be running a bunch of sophisticated assays to see whether there's evidence that one sequence resulted in better immune activation. But unfortunately, at the end of the day, what we didn't see was any partial responses. PR is how we talk about tumors shrinking. And in prostate, when it's in the bone, we can't really measure a PR, right? Because our tumors in the bone don't shrink. You can always just see scar tissue, so you don't know, is it live, is it dead? It's not really getting smaller. But some men have lymph nodes, and some men usually have lung or liver soft tissue that we can actually measure shrinking. We were hoping to see at least a little bit of shrinking, but we didn't. So this is not going to be a winning combination, unfortunately. But what we did see is the time for the cancer to start to grow and spread to new places, we call that PFS, or progression-free survival. And the R just means radiographic, meaning we do a CAT scan, a bone scan, and we don't see new tumors. We don't see old tumors growing. So it was a bit longer in one sequence, 8 months versus 6 months for the other, and really both of those are not bad. You know, if you get a treatment and your cancer doesn't grow for 6 or 8 months and you're not having a lot of side effects, then that's not a bad deal. Of course, we would rather see PSA go down and tumors shrink. So this is not going to move forward. We're a bit disappointed, but because we had these wonderful brave volunteers who participated in the study and we drew all their blood, we will learn about whether our hypothesis about activating the immune system and then not allowing the brakes to be pushed or the off switch to be pushed, we'll learn about that. So it's still valuable to the science. So here's what I was saying about the immune checkpoint inhibitor. In this case, this is pembrolizumab, which is Keytruda, and responses in prostate. So again, the waterfall plot, this is for men who had soft tissue that we could watch it shrinking. You can see some had some shrinking, but most really didn't. And then this is PSA changes. So some PSAs went down, but really the vast majority did not. So it's a nice graphical way to say most guys don't benefit from Keytruda with prostate cancer. So back in the day, before I was at USC, I was at the Angeles Clinic, and we were running this trial with ipilimumab, which is a different off switch, it's CTLA-4. And we were giving a dose of radiation with the ipilimumab, or just the ipilimumab, and we didn't really see a difference. And then they launched the phase 3 with the radiation, and it was negative. But so again, like definitely some men benefit from these checkpoint inhibitors. You have some bars going down, but most men do not. So we're still looking for ways to make them work better. One way that we can select patients better for this treatment is by doing genomic testing. So hopefully you guys have had a talk on genomic testing. I think I saw in your bank of videos someone had come and talked about liquid biopsy, where we can find cancer DNA in the bloodstream. That's a good test, especially if you only have bone involvement. But if you have soft tissue, the tissue tests are a little bit better at this point. And so why do we want to sequence your cancer's DNA and find all the mutations? Well, 3% of the time a prostate cancer patient will have MSI. It's microsatellite instability. When you have this on your DNA sequencing, we've won the lottery, because now Keytruda is going to work about 50% of the time instead of 9%, which makes it more worthwhile to do it. It's still not everyone. And so one of my patients, I was so excited. I'm like calling him, you have MSI, we can give you Keytruda. And after a few doses, his cancer was growing, so it was pretty disappointing. But clearly, you have these guys. So these guys have been on it for 80, 90 weeks. So that's what, a good year and a quarter, year and a half, and still benefiting. So if you have genomic testing, it should always report out your MSI status. If you have MSI high or MSI detected, then you can talk to your doctor about whether you can get pembrolizumab or Keytruda. So we can block PD-1, we can block CTLA-4. In other cancers, putting those two off-switch blockers together has been successful. So like in melanoma and in kidney cancer, we use this combination. This was presented last year, and people were like, oh, what do you think, what do you think? You know, less than a third of patients could even get 4 doses of this combination. That tells you this is strong stuff. And if you can't get the treatment, unlikely you can benefit from it. So they had 6% of the patients have a complete response, like meaning all their soft tissue cancer shrank, which is great. But overall, not so many people benefit, and the toxicity was quite daunting. I want to say they had like 5 deaths from side effects. So you have to weigh that. If you hear people talking with a lot of excitement, I agree these drugs are exciting, but I'm not sure in prostate, for the unselected patient, that the benefit outweighs the risk. All right, so moving on, cabozantinib. I don't remember if I've ever talked about this with you before. It's not an immune therapy, but we're learning to use it as an immune augmenter. What it is actually a pill that blocks certain signal pathways in a cancer cell, specifically angiogenesis, right, formation of new blood vessels, and then MET, which is used with hepatocyte growth factor. And it was studied in prostate because of this. They had patients whose bone scans went from lots of spots in the bone to completely normal. It was quite dramatic. To this day, I don't think the jury has fully decided whether this was an artifact or whether it really meant there was anti-cancer effect. Because, you know, some data showed that when you got this, you also got less pain and you got less PSA, so it seemed like it was the real deal. But then when they did the phase 3 test of just this pill in prostate cancer, it didn't meet the bar to get FDA approved. It definitely helped some men. I had patients on the trial who had failed everything, their cancer was rampant, and this stabilized it. But it's tough stuff. And one of the reasons people talk about maybe the phase 3 trial was negative is that they used a dose that most people just couldn't tolerate. Again, if you can't get the treatment, it can't help you, right? So what we learned subsequently is that this drug, whatever it's doing, seems to help the immune system. It gets rid of some of our negative immune cells that try to tone down immune responses, what we call Tregs or MDSC. And it might upregulate other factors that can help the immune system recognize. So there's a lot of work being done on the immune activation aspects of cabozantinib. So this was presented by my friend Niraj Agarwal from Utah, Huntsman. We are participating in this study. It's a combination of cabozantinib, the pill we just talked about, together with atezolizumab, which is Tecentriq. It's a PD blocking antibody, checkpoint inhibitor. And the study is a monster study. It was mostly cohorts of bladder cancer and kidney cancer because these drugs are used in those cancers, but not in combination yet. And then they had 30 guys with prostate. You know, I think the cabozantinib people, after their phase 3 didn't meet the bar for approval in prostate, were understandably hesitant to invest more, but I kept at it. I kept saying, you know what, guys really can benefit from this drug. We just have to figure out who they are or how to use it better. So thankfully, many years later, we now have this, and the first 30 patients, they saw all kinds of good responses. Guys with liver metastases, which is one of the most aggressive things that can happen in prostate cancer, having their liver metastases melt away. They were so encouraged by those first 30 that they added a couple hundred more slots for prostate cancer. So these were the data for the first 44 patients with metastatic castration-resistant prostate cancer who got this combination. They selected patients who had not yet had chemo. and patients who have soft tissue disease. So this is not your everyday prostate cancer patient, right? A lot of guys only have spread to the bone and wouldn't have qualified, and we don't know how this is going to work in that setting. But in their phase 3, they had gone back and looked and like, oh, maybe the guys with soft tissue were some of the ones who really benefited, so that's why they selected that for this. They can also then show tumors shrinking when you have something in the soft tissue, which gives like a quick and dirty estimate of how often it helps. And I think this looks a lot better than some of the waterfall plots we looked at earlier, right? It's still not as many as we would like, but there are a lot more guys whose tumors are shrinking. Now, side effects, there are. Okay, cabozantinib is an everyday pill with everyday side effects, things like diarrhea, fatigue, peeling of the hands or feet, mouth sores. They're very predictable. So the good news is we know when they're going to happen, what they're going to look like, and how to make them better. And people can stay on a pill like this for a long time because we can manage those side effects. The atezolizumab, the Tecentriq type drugs, I don't know how many of you have known someone who was on it. Sometimes people come to me and say, ooh, I never want to get that because my friend had it and they developed a terrible lung inflammation and pneumonitis, or they developed a terrible colitis inflammation in the intestines. So the side effects are rare with these drugs, but they're totally unpredictable. We don't know what organ is going to be hit, and we don't know when. It can happen after your first infusion, 3 days later. It can happen after your 30th infusion, a year later. So that's what's difficult about them, is it's not so predictable and manageable. But these drugs have been on the market. Thousands and thousands and thousands of cancer patients are receiving them, and we know now how to recognize the side effects and how to jump in and treat with steroids and shut it down. So I think they're actually quite safe, but I just wanted to spend a moment talking about that unique side effect profile, because I realized I hadn't really told you anything about the side effects of these drugs. So this is just a select list of some of the ongoing combination immunotherapy trials. I listed the NCT numbers, so later on, if you're someone who's looking for a trial, you can pull this, I guess, off the website, and then if you put this number into clinicaltrials.gov, you can look and see who in California has some of these. All right, so let's talk about the new, really, really powerful ways to activate the immune system. We'll start with CAR T. So CAR T therapy is where we genetically modify T cells. So we have to collect them, just like with Provenge, where you have the leukapheresis. So we do that for CAR T, except we set the machine to collect a different kind of cell. In Provenge, they're collecting dendritic cells. Dendritic cells are the teachers. So they're the ones that if a T cell comes up, they say, hey, this is something you should be looking for, or you should activate if you see this kind of thing. So when you get your Provenge, those teachers have to go out into the body and set up shop and start encountering different T cells and make that immune response. That's why it takes a while to see the response. When we take out your T cells and then we use a virus to put in a different gene inside the receptor, so every T cell has a receptor, it has something that when it's walking around it can grab and stick to. So you have some against influenza and some against coronavirus, hopefully, and some against other bacteria and viruses, right? We're going to reprogram the T cells we collect all to attack the same thing. So we use a virus, put in that gene. There's also some other aspects of how we tweak things to make it more likely to attack cancer and less likely to attack self, and more likely to stay alive and be active longer, but I didn't go into too much detail about that aspect of what we're modifying. But in its simplest form, we're reprogramming T cells all to attack what we want it to, so we take a prostate cancer protein and make hundreds of millions of T cells that want to attack that protein. So it takes about a month once we've collected the cells. We have to not only use the virus and then make hundreds of millions of them, then we have to quality control. We check them, make sure they're the right kinds of cells and that there's no contamination. So it takes about a month altogether once we collect the T cells. So at Save Hope, we're running a unique, one-of-a-kind a trial of an engineered T-cell product that was designed by Safe scientist Saul Priceman. So he chose PSCA as his target. That's me doing that, isn't it?
No, that's me. I'm sorry.
Okay. As it is, I feel like I have to move my head this way so I don't bump this. But so PSCA is prostate stem cell antigen. So this is expressed in prostate cancer, about 80% of the primary tumors and 90% of metastatic deposits. So it's not 100%. So to get into our trial, we're testing to see if a person's cancer in fact expresses this protein. Any good immunotherapy target is going to be expressed on cancer cells and not on normal cells. We don't want to give you hundreds of millions of T cells that are going to attack normal parts of your body, right? So it is expressed a little bit in the stomach lining, but with most other immunotherapies that have a similar feature, we don't tend to get a lot of stomach problems. We have to see what happens with ours. It's also expressed in bladder and pancreatic cancer. So one thing I like about this target is if our CAR-T works in prostate, we can also test the same product for patients with bladder cancer or pancreatic cancer, so that'll make it more broadly useful. So this is mouse work done by Dr. Priceman. So before we can put something like this into human beings, obviously we have to show that it has some chance of working, and so a lot of that work is done in mice. I hope this doesn't offend. I apologize if it does. But essentially, these are mice with tumors, a mock CAR-T, a CAR-T engineered one way, and then the CAR-T engineered this way, and you see now mice are surviving cancer-free. It's the bottom line of all that graphic. So this is published. The 4-1BB is the co-stimulation that we're using because we think it gives us the best anti-tumor effect. Some other T-cell products use CD28. So this is a poster I presented up at GU ASCO, Trials in Progress, just to let people know we're doing this. So our CAR-T trial is up and running. We've treated 4 patients. We've collected cells for the next couple of patients. We can only treat one every 28 days as per FDA. We have to watch them for 28 days to see what kinds of side effects. And then it takes us about a week to file all that paperwork. So we're limited in how many people we can treat. That's why we've only treated 4, but the next patient is coming in a couple weeks. The first 3 patients only got engineered T cells. They did not get any sort of chemo. So I'm taking a step back. CAR T cells are being used right now in an FDA-approved way for leukemias and lymphomas. And in those, they obviously don't target PSCA, they target CD19 or something that's expressed on the leukemia or lymphoma. They give a certain kind of chemo before they put in the new T cells to kind of wipe out the old T cells, because some of them might be suppressive and might work against the new T cells. And also, some of us think maybe to clear out space in the gathering places of the body for the immune system, like the lymph nodes and spleen. So they give this cyclophosphamide and fludarabine chemotherapy. We were hoping that our T cells might not need that in prostate cancer, because it's not leukemia or lymphoma, it's not in the bloodstream or in the lymph nodes, it's in other places, often the bone. So we treated the first 3 patients just with the T cells, even though the likelihood, based on other mice studies I didn't show you, and based on what happens in leukemia and lymphoma, we suspected that chemo would help it work better. So the first couple patients didn't really respond, and we were pretty bummed that we said, do we really have to treat the 3rd patient? We had designed it to be 3 patients, and then we moved to the next 3 to get chemo and the T cells. But we went ahead, and sure enough, the 3rd patient actually had some cytokine release, which we'll talk about, and had some PSA go down. So it's a good thing we did that, because now we have some sense that our T cells alone have the ability to be active. Our 4th patient was the first one to get chemo and then the T cells, and he's really having some nice response, so we're pretty excited. We don't have his day 28 scans yet, but I'm pretty optimistic. But there are side effects, and we'll talk about them on a future slide. So we're going to treat 2 more with chemo and 100 million T cells, and then the next group is going to get chemo and 300 million T cells. And we're just super, super excited. the scientist is in the room with me and the patient when he gets the cells. It's because we're so grateful that someone's willing to take a risk with us and place their faith in us. And we're really hoping that we're finding a treatment that's going to change prostate cancer therapy. If we can induce the kinds of long-lasting remissions that they get in leukemia and lymphoma, this would be really, really important. So we're really excited, really grateful. We're doing some really interesting work. This is a slide of circulating tumor cells. So we're working with Peter Kuhn from USC on this. It's being funded by Prostate Cancer Foundation. So Peter Kuhn does this epic CTC, no cell left behind, they call it. They just kind of smear the blood and then they can look at all the cells they've captured. A lot of the other companies use a selection where it goes through beads and only if they have certain things they're captured. Here we can see the whole spectrum of what's there. And so he's going to be able to see the CAR T and the cancer cells and whether they're expressing PSCA. We're going to be able to really learn a lot from these studies that we're doing as part of the trial. So what is the side effect of CAR T? It's cytokine release. When you put in 100 million attackdowns and they all start attacking, there's all kinds of juices that are let loose and inflammation that happens. So cytokine release is first and foremost fever. So our second two patients, I guess, our patient number 3 and patient number 4, had fevers, 102, 103. They felt pretty crummy. It's not easy. That's why we give it in the hospital. So we actually do the chemo in the hospital too, just logistically. Hopefully I can make that go away at some point. And then we give the T cells in the hospital and watch for 7 days. Around day 3 or day 4 is usually when we start to see the fever spiking. And so we just want to be able to give you Tylenol and antibiotics if you need them and whatever to get you through that. And then there's an antidote called tocilizumab. If it's really bad, we give the rescue, the tocilizumab, and that shuts the cytokine release down. So both patients are waiting for tocilizumab. And it's used in the leukemia lymphoma. In those diseases, when you get cytokine release, it's a good thing. It means something's happening. So you kind of want it, but you don't want it to be too severe. You don't want the patient to feel so sick and have to go to the ICU. And so you give the tocilizumab if things are getting severe, getting strong, and then it shuts it down. So they use it, and we wrote it into our protocol as well. If the cytokine release gets really too active and you don't give the rescue, what could happen? You could start to have low blood pressure. You could start to have trouble breathing. So again, this is why we're doing it in the hospital and moving into ICU. But hopefully that won't happen because we jump in. We have a lot of people who've given hundreds of CAR T cells for leukemias and lymphomas and know when is that right moment to rescue a patient. The other side effect that happens with CAR T is harder to explain the why. So 2 weeks later, for whatever reason, some people will start to have a little confusion, neurologic side effects. So while they're in the hospital, we have them write something 3 times a day so we can look whether their writing is changing. Because one of the earliest signs is that the writing changes in subtle ways. But it can get all the way to confusion and not being able to talk right, being real sleepy. So it can get kind of worrisome. This is usually treated with steroids. I did have this happen in a patient who got a BITE antibody, which we're going to talk about next, which behaves very similarly to CAR T. And it was pretty profound. He went from running 5 miles a day to really out of it. And it was really scary for him and his wife. But we gave him steroids, and 24 hours later he bounced back. He walked out of the hospital and went back to running within a couple of weeks. So it's reversible, but it is one of the scary side effects of CAR T. And that's why in our trial, patients have to stick around within 30 minutes of our cancer center for a month. So you're in the hospital for at least a week. Sometimes you have to stay in a bit longer if you're having still some cytokine release kind of symptoms that we're toning down. And then we need people to be nearby in case any of this pops up. All right, so BITE antibodies behave like CAR T, as I mentioned, and we've got 2 studies at City of Hope using these. So what are they? They're antibodies that grab a T cell and grab a cancer cell and stick them together and turn on the T cell. So instead of making hundreds of millions of T cells to attack, this is a different way to go about it. But when the T cell attacks the cancer cell, and we're giving millions of antibody particles, right? So lots and lots of T cells are attacking cancer cells, so you can get that same kind of inflammatory situation with cytokine release. So Amgen has made a couple different BiTE antibodies. They started out with this 212 against PSMA, prostate-specific membrane antigen. Some of you will have heard of that from PET scans that we can do at UCLA, but they're not yet approved, so they're cash pay. But they're really, really good PET scans, and it's a good target in prostate cancer. So Amgen has a BiTE that's approved for leukemia lymphoma again, and then we're applying this now to prostate. So 212 was the first one that required continuous infusion for I think a month, kind of in the hospital for a month, which is a lot to ask. And they saw some PSAs go down, and they had a couple guys with long-term responses. So this was kind of proof of concept, but they just had to tweak it to be a little more user-friendly. So they made Amgen 160, same target, but they formulated it in a way that you don't have to get it continuously infused. You don't have to stay in the hospital for weeks. You just have to stay in the hospital for a few days for your first couple of doses when you're getting cytokine release, so that we can give tocilizumab if we need it. So far we haven't needed it, thankfully, or we can just support you through the fevers until that simmers down. So we're running the Amgen 160. I've treated 4 patients. And my 2 guys who are on it right now seem to be benefiting, which is super exciting. They have, in one of the higher dose cohorts, a lot of PSAs going down and tumor shrinking. So I think this is going to be the real deal. The question is, how can we make it even a bit more user-friendly? Because patients are still in the hospital 4 days a week for a couple weeks, then they get a week off, then they're back in for 4 days, and they're out. It's a lot of hospital time. So it's a bit of a price to pay, but if we can get some really long-term responses and maybe shorten the hospital time, eventually it is given outpatient every 2 weeks, because the cytokine release kind of dies down, your body doesn't have that big inflammatory reaction, maybe because there's less cancer to kill after multiple doses. Just making it more user-friendly, I think, will be helpful in moving it forward. The other thing they did is they made this 509. So it's against a different target called STEAP1. I forget what that stands for. The P is for prostate. I forget what the STEA is. But they found that that's a good target for prostate cancer, and they've designed it in a way that they think will cause less cytokine release, so you're only in the hospital for 2 days instead of 4, which is already, I think, a big difference. So we haven't gotten that one up and running yet, but we're about to, and so we're excited to see how that one will perform. So these trials are mostly for people who have been through hormone therapy, and they've been through Zytiga or Xtandi, and they've been through chemo. These are patients who are looking at not a lot of options that are going to really extend their survival, and so not everyone's willing to do it, but people who are willing to invest the time, we're hoping that's going to be rewarded with nice long remissions, and I will have to update you when we have more data. So there's so much we don't know. I feel like we learn something every single day. That PhD scientists and I are on the phone constantly, like, oh, this happened to the patient, what does it mean? And oh, let's figure it out. And does that mean for the next iteration we're going to add Keytruda, or are we going to add radiation, or what are we going to do to get this to work even better? But so these are some of the things we don't know. What's the optimal target? So we're running the PSCA CAR-T. We also are opening a pharmaceutical company CAR-T against PSMA. So Poseida is making it, and we're going to consent our first patient tomorrow, which is pretty exciting. UPenn has a PSMA CAR-T that's being funded by Prostate Cancer Foundation, and then there's one other company that has one, and they just opened it at Columbia. So these are starting to get out there because people are excited about this, but we don't know which one's going to be better, PSCA, PSMA, STEAP1, the Amgen 509 antibody. We don't know which patients are best. It might be that, we usually start testing these in patients who have been through chemo, for instance. Maybe if they haven't been through chemo, they'll have a better reaction. We just don't know, but we tend to start in later populations and then move it forward. We don't know whether these T cells, whether we're activating them with antibodies or engineering them outside of the body, whether they actually get into the tumor. I will say on our CAR-T trial, we're doing a biopsy after treatment. That's going to teach us so much because we're not seeing necessarily a lot of T cells in the blood, but that's okay. We don't need them in the blood, we need them in the tumor. So we're going to take biopsies and hope to see that our CAR-T has gotten in there. And if not, or if they're there but they're not working, then that's gonna teach us what to do in the next trial, what to add, how to tweak our treatment. So one thing that a lot of people talk about, and I mentioned this earlier, is that radiation might turn a cold immunologic tumor into a hot immunologic tumor by killing cancer cells in a way that makes them more visible to the immune system. So prostate cancer is thought of as a cold immunologic tumor. The immune system might walk by and not notice that anything's going on here, but the hope is if you radiate it then, all this stuff is spilling out and then the immune system will stop and take a look. We don't actually know if that's helpful, but there's a lot of studies going on trying that. And we may do that too. We have to see what we learn from the biopsies. And then do the T cells get exhausted? So that's where, like with the proband, our hypothesis was we were activating, but then the off switch was being pushed. So is that going to happen to our T cells? Are they going to get into the tumor only to be turned off or get exhausted? So that's where we could conceivably think about adding a PD-1 blocker in a combination study. So where are we today? Immunotherapy for prostate cancer, well, we have proband. It's the only one that's FDA approved. It's good, it's not as good as we would want. We haven't found yet a great combination to make it as good as we want, but we're gonna keep working at it. In the meantime, I do think that it is an important treatment option, not for every prostate cancer patient, but for many. And I think these T cell strategies, I truly believe in them. I don't think I could look my patients in the face and get up in the morning when my patient's in the hospital having their fevers, if I didn't truly believe that this might be a way to help put them in a remission that would last years, right? That's what we're aiming for. Don't want to say cure, but of course that would be a goal. But even just a really long remission where they're not on chemo and then on this and then on another thing and having their cancer grow, I think would be really great. So, but it's not for the faint of heart. Boy, do I have people calling me up asking me to get on the CAR-T trial and they're just starting their hormone therapy. And right now we're still learning, and it's better to go with the tried and true until I can tell you how often does this therapy work and what's the trade-off in terms of side effects. All right, so that's all I have. Thank you for your attention.
Thank you very much, Doctor. We'll start getting some questions on this, and then I'll start working my way to the back of the channel.
Maybe you explained this, but I don't recall. In the CAR-T cell therapy, is there just one dose? Is it an ongoing dose? Is question number one. And question number two, could you expand a little bit more on the toxicities? I've heard fever. Are there irreversible toxicities that would continue?
So the first question, very good question, very astute. So we are doing a single dose. The Poseida trial that we're opening has different cohorts. Some get one dose and some get multiple doses. So when we pull out your T cells in the leukapheresis, we can make many hundreds of millions. And so even in our PSCA CAR-T, we're making more than we're using, and we're banking them. So if we found out that 300 million with chemo was fantastic, a guy who got 100 million could conceivably come back and say, hey, you still have my T cells, can we try it again? So we don't know whether you need one dose. In leukemia lymphoma, it's one dose. You're cured or you're not cured, you get your one dose. I think there have been some retreatments, but largely the excitement in part is because one dose is all it takes. I will say some of our other trials, so we have CAR-T for brain cancer. We've seen really nice remissions. They put the CAR-T right into the circulation of the fluid around the brain, published in the New England Journal, complete remission for a glioblastoma patient. They're giving those every week. Our liver cancer trial with CAR-T is giving every 2 weeks until they run out of cells, so maybe 8 or 10 doses. We have one for HPV cancers. We have one for HER2 cancers, like for breast cancer. So we're studying CAR-T in a lot of different cancers, and some are giving multiple doses and some are giving one. So we don't know what the right way is yet. But our trial, we have one of each, sort of. The second question about the side effects. So cytokine release is first and foremost fever, but it can have other components like lowering the blood pressure, shortness of breath. You asked, I think, the heart of your question, is there anything irreversible? Cytokine release should reverse. We have this antidote called tocilizumab. So should not be permanent. The neurologic toxicity I talked about, where people can get confused, it can be pretty scary. In my experience, reverses pretty quickly with steroids, and in the literature, should be reversible. Sometimes it takes a little longer, but does not stay permanent. No one's permanently in a coma from it, for instance, or permanently confused. And there's not really organ damage. You know, this is a very focused kind of immunotherapy, so unlike the Keytruda or Tecentriq, where we're taking off the brakes or the off switch, and your immune system can attack your lungs or liver, there's not really a reason why a CAR T would do that, or a BiTE, because we're making it very focused at one protein. So we just don't see that. We have seen a little bit of rash, but nothing like kind of organ damage that would be permanent toxicity. There have been some patients who have died on CAR T. Not on my trial.
That's a side effect.
Yeah, so when you get your fevers and you have had chemo to lymphodeplete, right, the conditioning chemo that we use with CAR T, people can get infections and they can die from that, right? So again, one of the reasons you're in the hospital is when the fevers hit, we'll often throw antibiotics into the mix because we don't want anyone to die. But if you look at the clinical trials that are published for the FDA-approved CARs, you're going to see not everyone makes it. Some of them are dying from their cancer, probably most of them. And I think, you know, we're being very, very careful on our trial. We want zero deaths from the CAR T. And so far, all my patients have made it out of the hospital, whether they responded or not, need other treatments or not. You know, that's my goal. But in full disclosure, and people die from Keytruda and Tecentriq and Opdivo too, right? Immune therapy, your immune system is incredibly strong.
Any other questions? Any other questions? No other questions.
Oh, that's a good question.
So I'm seeing a doctor, seen for 18 years, and I'm on the enzalutamide and Loperib, and I haven't yet had Gestana or whatever. So I just wanted to reflect back what I heard you say, that this isn't necessarily just end-of-life therapy, but it's certainly, you only would propose it for patients who are have exhausted other remedies.
Yeah, so most of the trials require at least Zytiga or Xtandi, abiraterone or enzalutamide, and at least one chemo, Taxotere or Gestana. My trial doesn't require that. I require only that you've been through Zytiga or Xtandi, but almost everyone has had chemo also. And olaparib is, you know, another treatment that you can have had, that you don't have to have had. And I think it's very individual. There are people who really feel like chemo will always be there. Why do I have to go through chemo to get to your treatment? But most people would look at it and say, gosh, it's a lot of hospital time. If I can have my life extended by chemo, I'll do that. And then in the meantime, the immune therapies are going to be getting better and safer, right? So I left my trial a little bit flexible because some people get radium-223 and don't get chemo and might be a reasonable candidate for this. But a lot of the other trials are very strict. One from column A, one from column B. So abiraterone, enzalutamide, Distancel.
I've been tax situation. Is there, can I ask your process of taking people into the program? Like, is it, should someone apply, get paperwork in so you know who they are? And how do you make the selection? Is it from doctors calling you and saying, hey, this is a really good patient? Or should I come to you and say, hey, look, I'm not desperate yet, but only time will tell? I'm just trying to figure out what the process is.
So that's a good question. When is the right time and what is our process? It's difficult because I can only treat one every 5 weeks, and there's a wait list. And so if people come to me too late, which has happened, then they don't have time to collect the T cells, engineer them for 4 weeks, and then get them. Now, we do allow people to get whatever kind of treatment they need in the meantime. We wrote it very flexible because at the end of the day, we want what's best for the patient. So a lot of patients come in, get their T cells collected, and then in the month or 2 or 3, depending how my wait list is going and how the trial's going, they'll get some chemo, or they'll get olaparib, or they'll get Xtandi, they'll get whatever can help control their cancer until they're ready to be admitted and get their T cells. So we're trying to be as ethical as possible about that, as well as about the process of selecting. So people have to be strong enough. The oldest patient we've treated is 73. So when an 80-year-old approaches me, I can't yet tell them how safe this might be for them. The first couple patients we treated were 50s, 60s. We just wanted to play it safe. We look at disease burden, and in some ways, someone who still has some options is a better candidate, because if I have their T cells processing and they need a little chemo to keep them going and they're not yet resistant to chemo, that's kind of a plus. But it's really a conversation. If you come to me now, my wait list is very long. But coming to me so we can talk about it, make sure people understand what they're getting into, because now you guys all do, but a lot of people don't understand. They think you come in, get your T cells, go home, and it's like prevention, but it's not, right? You've learned that. So I have a conversation with the patient. We check their tissue for PSCA staining. And that can take a few weeks too. If your tissue's at some hospital somewhere, we have to get them to send it, and then we have to run the test to see whether the marker is there. So I would say maybe in a couple months I'll have more availability, because I'm opening this second trial, which is going to help shorten my wait list.
So to get on the wait list, would that be something worthwhile to do now? Is that like going on your website?
I don't know. I think my research nurses are about to kill me because the wait list is quite long. So I think they would probably prefer that we get people tucked in and get people treated and shorten the wait list and then start adding to it than to add to it now. But if I don't know you're out there, when I have a slot, I can't grab you for it. So in some ways, I like having a pool, and I say, go do this next, and I'll call you when I have a bite slot or when I have a CAR T slot. So in some ways, it's not too early.
So do you take an appointment first, or do you want paperwork off your website?
Appointment first, usually. Yeah, because then we can, now you've heard me talk, but most people, we have people flying in from New York and Chicago and Brazil, and they've heard about this CAR T, but they don't really know what it is, and so we want to have that appointment to make sure before they get into it that they know what they're getting into.
Thank you very much. Anybody else? Does anybody else have questions? Oh, right over here. Okay.
When you have a cytokine reaction and you use your steroids to knock it down, you said it's pretty effective, very effective. Is that administration of the steroids continuous, or do you taper down?
So good question. The question was, when you have cytokine release, and usually for cytokine release, we just give a dose of tocilizumab. It's more for the neurologic that we get into the steroids. Do you have to give ongoing steroids? So as background, with a drug like Keytruda or Opdivo, if your immune system starts attacking your liver or your lungs, you often have to be on steroids for a month or even 6 weeks, because you have to shut down the immune reaction and then slowly back off of the steroids. With the CAR T, it's usually just a quick pulse. Honestly, my guy with the BITE antibody who had the neurologic toxicity, it was like a day and it reversed, and we took him off the steroids within a few days.
Anybody else? Any questions?
I have a quick question. What's the average age of your patients?
The average age of my patients, I haven't added it up. I definitely have some 40s, if you can believe it. I have a lot in their 60s, 70s, so maybe my average is like 65, 70. I have 80s and 90s. They're not going on this really super strong immunotherapy yet, but a strong 80-year-old I would consider if they were interested. 90-year-olds I find a little more fragile generally.
So why would somebody average at the age of 70, over 70, want a treatment from you?
That's a good question. Why would someone over the age of 70 want to do one of these treatments? Some of you may have been on hormone therapy for a long time and may not like being on hormone therapy for a long time. Some of you at 73 are actually healthier than some of my 50 or 60-year-olds and have a lot you still want to do. So my current patient who got the CAR T, who's 73, has a lot he still wants to do. He's in good shape, he exercises, he's doing work that's very meaningful to him, making the world a better place. And so I think some people also go into it saying, even if it doesn't end up helping me, if I'm part of the process of creating a new treatment that ends up being a game changer for the next generation, some people find meaning in that too.
Thank you. Anybody else? Questions from anybody else? Anybody? Okay, very good. If there are no other questions, I think we can adjourn the meeting. Doctor, you would leave us with a few of your business cards so people can contact you. Thank you.
Can I help you for something? Would you please?
I'm going to have a screen an extension cord. Let me get you working at front.
At least I can say I'm treating.
Where basically that's this material.
Long to get the trial up and ready to get behind me.
The box is too heavy, let me know, and I'll put it back on the shelf. No big deal, it's about 50 pounds. And we'll get